a good way to get their attention, right? I'm floating the angels. Okay, there we go. Good afternoon, everybody. We'll go ahead and get our training started today. We're excited. It's been a conversation we've had for quite a while, bringing in stimulant use disorder training for our community. As we know, this is a very challenging area we're trying to learn more about. Couple of logistic things before we start the training. If you're not familiar with this space, restrooms are, if you go out this door, just make a loop around the building. They're right, basically behind this wall over here. Take care of yourselves if you need to throughout the training. Please make sure that you sign in. For CEU purposes, we will be recording today's session in order to justify that we've had this session take place. And then working with the Opiate Response Network, we will get those CEU certificates to you after the training. There will be an evaluation that we'll ask you to complete as well. With that, I'd like to introduce Danae DiRocco.
Yes.
Thank you. Who is our presenter today. And thank you to Jen Ferreira for working with the Opiate Response Network to bring Danae here for this training day. So for that, thank you.
Okay. Welcome, everybody. Thanks for joining. I'm excited to be able to talk to you guys today about stimulant use disorders. And I have about an hour and 15 minutes worth of slides. So we have 2 hours, and I'm hoping that will mean that you guys will ask questions or if you have cases that you want to talk about, or like just interactive, don't feel like you can interrupt me. I want this to be a learning experience that you guys take value from. So I'll talk a lot, but I would love to hear from you too. So I am with the Opioid Response Network, and what that is let's see here, let me get the clicker working. Okay, I might need a little help. I'm not knowing how to do this. Hold on, let me try. There we go. Okay. So what the Opioid Response Network is a SAMHSA-funded grant that assists states, organizations, and individuals in technical assistance around opioid and stimulant use. So anyone can request a technical assistance through the Opioid Response Network for information on evidence-based prevention, treatments, different things that you might need in your community to address stimulant and opioid use issues. And the requests are for education and training. We do not do direct like patient care or interventions around patients, but we do offer training for communities and organizations as well as individuals. I think the very first Opioid Response Network request was from a grandmother who had a grandchild with substance use disorder and wanted to learn more. Churches will request information, things like that. And so just so you know, if anyone else has any additional requests, they can be granted here. This is how you would request one. If anyone wants to take a second to jot that down. No charge. Correct. Thank you. Yes, it is all no charge, paid for through the grant so nothing comes to you in terms of cost. I don't have any financial disclosures to discuss. All right, so today what we're going to talk about is stimulant use disorders, and we're going to kind of go through some of the epidemiology of them, what stimulant use disorders is looking like now in the country and in the state of Ohio. And my goal is really for you to understand signs of intoxication, overdose, and withdrawal, how you can identify evidence-based treatments, both behavioral interventions and medication interventions to treat stimulant use disorders, and then hopefully be able to name a few comorbid medical or psychiatric conditions that come along with stimulant use disorders, where patients might be presenting to you with maybe something else that's related to their stimulant use. All right, any questions before we dive in? All right, actually, maybe before we do that, I should ask, who here is like a medical provider of some sort, nurse practitioner, PA, MD, DO, anything like that? Any prescribers? Okay, what about like nursing, social work? Okay, good, great, social work condition. Like other community providers, mental health, or, okay. Awesome. Hi, mental health people. I'm a psychiatrist. So. All right. And then anyone else, I guess maybe just shout out on what am I missing? What other community agencies or Peer support. Oh, yes, thank you. Great. Okay. How many peer supporters? Yes. Welcome, welcome. Okay. Awesome. All right. This is a little more medically focused, but there's a lot of other information in here too. And so hopefully it'll be useful for everyone. And then if you have other questions or anything, let me know. All right. So let's talk a little bit about what we're seeing now. So there's been these kind of waves described in terms of substance use overdose in particular and like use. And so stimulant use obviously is not new. Stimulants have been around for a very long time. Just like opioids, alcohol, all substances of misuse have existed well before 1999. But this is really when we started looking at big overdose death shifts, starting to recognize this as a public health emergency and starting to try to address it. So this graph looks at wave one in the green is where we see, I'm going to try to do this. So a rise in prescription opioids, and that was really kind of the kickoff of a lot of the concern around opioid prescribing, opioid overdose deaths, and then people turning to heroin and other street opioids. In the purple, we have a rise in heroin use. That was sort of people turning from prescribed things as they got harder to get to street opioids. And then wave three in the blue is where we start to see around 2013 a huge increase in fentanyls and synthetic fentanyls on the street. And that really led to this huge spike in overdose deaths. So the blue is where we see fentanyl overdose deaths without stimulants involved. And in the red, around 2015, we start to see a peak of fentanyl with stimulants involved in overdose deaths. And so this red line is where there's a lot of concern now because we are starting to see overdose deaths from fentanyls come down, but we're continuing to see a lot of stimulant involvement in overdose deaths. And so we want to start addressing that. I think not that we've in any way ended the opioid crisis, but we've done a lot of good work in addressing it, but not as much to address stimulants. So, and then this graph is looking at the overdose deaths of fentanyl and stimulant presence, and this is data between 2010 and 2021. So deaths involving multiple substances, including fentanyl and stimulants, are rising quickly. And so, this is sort of more evidence that we need to move beyond opioid-only strategies in prevention and treatment. And so if you look at, this is national data, yes. And if you look at the purple bars, this is representing deaths from both fentanyl and stimulants. And so you can see we have very little purple. Around 2014 is where we start to see it. So in 2015, there was about 3.8% of all overdose deaths were a combination of fentanyl and stimulants. And now in 2020 or in 2021, so not even now, that is 32.3% of deaths are involved with co-occurring stimulant and fentanyl use. And so that is one of the largest single categories now by 2021. This was a study, so I don't have like the 22, 23, 24 data. Hopefully we will be able to get that data out here to compare, but we continue to see those numbers rise. Maybe not as big of a shift as we've seen here, but they're continuing to stay at that, like about a third. And so we need to address this, right? But how do we do that? So I'm trying to operate off of two computers here so I can check my notes. So this is the geography of the United States. Obviously, we see Ohio here in the yellow, and this is fentanyl overdose containing other drugs. And so we'll look more specifically here. This is for cocaine. So I don't know if everyone can read this, but the bright yellow that Ohio is in is 25 to 30%. So similar to those national numbers, Ohio is seeing around 25 to 30% as well, whereas some of the more northeastern states, like Vermont and Massachusetts, have a much higher percentage, around 45 to 50% of their deaths include fentanyls and stimulants. And then for, you know what? unfortunately, because this is a PDF, it's not going to show this other, the map of methamphetamine. What we see in the methamphetamine map, though, is it's much more red in the West. Yellow, Ohio is still yellow, the same color. So we're seeing both cocaine and methamphetamine have sort of a similar percentage of use in our state. But you see California becomes kind of bright red, as does Nevada and some of the other states out here. And then West Virginia is pretty bright red as well in terms of methamphetamine use. So the other issue that we're seeing is that deaths are rising among young people aged 25 to 54, but also there is a disparity in race. And so we're seeing that non-Hispanic, American Indian, or Alaska Native individuals had the highest death rate. Those are the orange lines here for men and for women. And non-Hispanic white individuals had the second highest rates, and non-Hispanic Black men had the fastest increases in death between 2011 and 2018. And so they are the black line. So you see the rate kind of shooting up a little bit there towards the end. So things to think about too in terms of populations, minoritized populations being more affected by these rises. All right. And then this study was one of the first to use a nationally representative sample of US adults who describe themselves as LGBTQ. And it was looking at disparities in the use of medical and non-medical prescription stimulants and illegal or like street stimulants. And the data shows for adults between 2015 and 2017 who had participated in the National Survey on Drug Use and Health, the NDSUD data, that's a nationally representative sample they pulled out for LGBTQ individuals. There was a higher prevalence of medical and non-medical stimulant use compared to their heterosexual counterparts. And higher drug use is likely a result of, from the study, considered to be minority stress. So exposure to stigma, discrimination based on their sexual orientation, that can result in health disparities. And they also highlighted how for bisexual individuals, that in the white bars here, that they seem to think that there was sort of a double discrimination that people were experiencing, both from heterosexuals and from fully lesbian and gay communities where bisexuals don't feel like they belong totally to either, and had particularly high substance use among those individuals. So, which brings us to talking about stigma. Does anyone remember these campaigns that came out? I can't remember exactly what year they were out, but these disfiguring tools of addiction and these comparisons of people's faces and oftentimes like mug shots that were being, yeah. So obviously PSAs usually have are well-intentioned. However, these are very shame-based types of interventions. So they really focus on physical appearance, reinforcing the idea that people who use stimulants are grotesque or disformed in some way, and really contributes to shame and like fear-based campaigning. And I think as everyone here or anyone who's worked with people with substance use, shame doesn't really help you get help or ask people for care. And what we want to do is try to reduce shame so that people are willing to ask for help, accept the help that might be available to them. And these kind of campaigns really don't do it. And I think there was a lot of these like around, celebrities and other things kind of showing what had happened to people as they had used substances. And it really just reinforces stereotypes and stigmas. And we want to stay away from that. All right, so our words matter as well. Language is really powerful. There's studies, looking at how like using the same exact case situation when a person is described as a substance abuser versus someone who uses substances, doctors are more likely to offer less treatment or more punitive treatments to someone if the word abuse is used in the description of the person versus use. And so I think it's really important that we model the language that we want others to use, or the way we want others to think about patients, and the way we want patients to think about themselves. So instead of saying, addict or junkie or all these words that hopefully are not in the vocabulary of people in the room, this is a person with a stimulant use disorder, or with an alcohol use disorder, whatever it is. Urines, we want to be as accurate as we can when we're describing like a medical test, and a urine sample that we're testing for substances is a medical test, and it is either positive or negative. It is not clean or dirty. A person is not clean or dirty. A urine is not clean or dirty. And so we want to move away from that kind of language and just talk about, like if I'm seeing a patient I'm prescribing Suboxone to, I would say maybe their urine is appropriate for prescribed medications, right? If it's positive for buprenorphine, that's what I'm expecting because that's what I'm prescribing them. And then things like, a newborn who's been exposed to substances versus something like crack baby, which is older language, but still shows up again and again. And then, when someone might be intoxicated with stimulants and be experiencing like hallucinations or psychotic-like symptoms, this person has an altered sense of reality, perception of reality, or you could just say person is hallucinating. Like those are medically accurate terms, but tweaking that they're crazy, those kinds of things aren't really helpful. And then even thinking about if someone's aggressive or behaving violently, or concerns about that, this is a protective behavior. They're in a state where they aren't, seeing reality the same way that we are. They're scared. They're trying to protect themselves, and that's what this behavior is about. All right. So what are stimulants? They cover a number of things. So they are amphetamines, including methamphetamine, or things like Adderall and other prescription amphetamines, betel nut, caffeine, and khat, and then not the synthetic, but khat, caffeine, and betel nut are all kind of like natural examples of stimulants. These are all plant-derived things. Caffeine is a stimulant, cocaine, and then synthetic cathinones like the bath salts that occasionally pop up as like popular for a little while and then sort of go away. They were all the rage a while back, and there was all these kind of salacious news stories about people doing, violent things to other people, and we see them crop up every now and then, but not as often recently. I don't know if you guys have seen any of that out here, any bath salts recently, or they're tough sometimes to spot because if they don't show up on a test and maybe people don't know what they were using, or they took something from someone else, or they bought something online. But so those are in the stimulant category, as is nicotine. All right. And then they affect dopamine transmission in the brain. So dopamine's a neurotransmitter, plays a key role in our reward system in the brain. It also impacts our activity levels in our body and then impulsivity. Cocaine and methamphetamine will both increase dopamine, but they have slightly different ways and in different intensities of doing that. So this is the first picture here, sort of normal dopamine transmission. You see there's just kind of a few little yellow depiction here of dopamine coming out of the synapses and binding down here to the postsynaptic neuron. With cocaine, what we see is that it inhibits dopamine reuptake, so the body doesn't reabsorb it as quickly. So dopamine levels are increasing, and this leads to heightened feelings of pleasure, euphoria. The effects in the half-life are relatively short, maybe 30 to 90 minutes is how long someone's going to feel the euphoria from the use of cocaine. Methamphetamine then not only stops the reabsorption of dopamine, but it also increases dopamine release. So there is a greater level of dopamine in the system when someone uses methamphetamine or amphetamines. And this leads to kind of more of a significant high and more of a prolonged effect. The dopamine levels tend to hang around a little longer. And the half-life of this is much longer. Instead of 30 to 90 minutes, it's more like 10 to 12 hours. And that's one of the reasons, too, that we see some more of the effects of like psychotic symptoms that can happen in cocaine, but typically are shorter lasting. Whereas with methamphetamine, if you're in a state of you know, lack, you know, out of reality or having hallucinations, things like that. When it's lasting for 10 or 12 hours, obviously those symptoms can kind of linger longer. When someone's experiencing those repeatedly, then with cocaine, where it might be a shorter period, they're back to reality a little faster and they don't have as strong of an effect on them. And so the excessive dopamine really is what's responsible for the intoxication. And then the dopamine withdrawal and the drop of dopamine is what leads to both the physical symptoms of withdrawal and like the psychological symptoms of like feeling really low, depressed, when we lose all that dopamine that was flooding our brain. All right. And then this is a bit of a transition here. So yeah, please.
With the withdrawal, the-
Mm-hmm.
what is the receipt for this time? I'm guessing, but, before, so it's gonna, so.
Yeah, that's a good question. We have like pretty clear information on things like that for opioids, like or alcohol. You have to use to build up a tolerance before you'll start to experience withdrawal symptoms. But with something like methamphetamine, you can still have kind of a post-euphoric, like withdrawal type symptom. It maybe not last as long if you've only used it once, as like your first time using it, but you will feel like that slump. You'll feel that loss of dopamine. So really, even one-time use, you're likely to have some withdrawal symptoms. Whereas with like an opioid, it takes some time for your body to build up like a tolerance to that. And then the loss of the opioid is what leads to the withdrawal symptoms. You can have, you know, in terms of like psychological symptoms, any drug is going to have like a dopamine hit, and then the loss of that is going to feel kind of crappy. So people are going to feel kind of bad after, you know, when even like you drink once and maybe you have too much, you're getting a lot of dopamine. The next day you may have a hangover. The dopamine's leaving as well as like the other physical effects of the alcohol being metabolized. But with methamphetamine, you don't have to like build up a tolerance necessarily to have withdrawal. Yeah. All right. So then why do people use substances or stimulants, you know, any substances at all? What we find with patients who use substances is that they're more likely to have ACEs or the adverse childhood experiences. Have people here heard of all my social workers know it. I know that. My nurses most people here probably have heard of this. So ACEs are adverse childhood experiences. So these are things like experiencing abuse, neglect, household dysfunction, things that might have negatively impacted your childhood. And people who have had those experiences are more likely to have issues with substances later in life. And ultimately, we see with patients who have self-reported stimulant use disorder that they also have higher rates of interpersonal violence, even into adulthood, more higher rates of childhood sexual abuse, higher rates of sexual assault across childhood or adulthood, and they're more likely to be victimized in a number of different ways, like physically and mentally. So things to think about, like I don't think I have to tell the people in this room, you know, that people use substances for a lot of different reasons, but masking pain, dealing with trauma, these are often reasons that people would turn to substances to feel good for a little while, to forget things, to have a break from emotional pain.
Are there any studies with correlating psychiatric disorders with either stimulant or opioid use?
Yeah, we know that about the range is like 40 to 60% of people with a psychiatric disorder also have a substance use disorder of any kind. And then kind of within, like we see more depressive disorders within like alcohol use disorder and opioid use disorder. And we see more psychotic disorders and anxiety disorders or trauma disorders within stimulants, but they can cross interact and you can kind of have anything. But that's really the data kind of shows like they split a little bit more along those lines. Or and then what's difficult in anytime you're diagnosing someone if they're actively using substances is like chicken or the egg, like what came first? Did you have psychiatric symptoms before you started to use substances, or did they start after? But regardless of when they start, they can always persist after substance use has started and ended. And so we always want to treat those people psychiatrically for whatever symptoms they're experiencing. There's no reason to withhold treatment just because someone's using a substance. We want to treat their mental health issues so that they're getting the help they need there. And that usually helps them to work on sobriety or other things if that's what they're interested in. And so we want to never withhold treatment just because, well, we think this is because you used cocaine. In my mind, it doesn't really matter if you use cocaine, we should still be treating you as long as, I'm not giving you a medication that's going to be unsafe to use with cocaine. We want to continue to treat your mental health issues. Does that answer your question? Okay. All right, and then this is a little bit of the diagnostic criteria that we use within the DSM-5, the Diagnostic and Statistical Manual of Psychiatric Disorders. And so substance use really kind of occurs along a spectrum. Because you use a drug one time does not mean you have a use disorder, though perhaps it could if like you're, having a ton of dysfunction in your life from that use. But really what we see is that there's kind of 4 buckets that we look at in terms of how a substance is impacting someone's life. So impaired control, meaning that they aren't able to control the amount or the frequency with which they use the substance. Maybe they start out being able to use once a week, once a month at a party, and then it turns into something where they feel like they need it more and more. They're not able to stop using it, or they're using it at times when they know that they shouldn't be, like before going to work or when caring for children or things like that, and it starts to interfere with responsibilities. They're spending more and more time spent either acquiring the substance, using it, or recovering from the effects of the substance. And then craving or a desire to use again and again can be a sign as well. And then social problems that may come from use. So neglecting responsibilities or relationships, even giving up things like hobbies or activities that someone might have enjoyed doing in order to use or because they've used. And then being unable to kind of function at home, school, or work. And obviously like interpersonal relationships being damaged by use are a sign. Risky use, so people using in settings that could make them unsafe or in ways that are unsafe, despite kind of knowing the consequences, like people who might use needles from someone that they know maybe has an illness or something, and not that using needles in and itself is necessarily a criteria, but risky behavior that they know could lead to infections or like not seeking out clean materials, that kind of thing, in order to use. And then continued use despite known health consequences, like someone is having their own physical health consequences or mental health consequences from their use, but they're continuing to use because they feel like they can't control it. And then physical dependence can occur, so needing more of the substance to have the same effect. We see this kind of more clearly in like opioids or alcohol, but we do have the same situation in stimulants where people may feel like they need more and more of a dose in order to get the same sort of early euphoria that they had when they first started using. And then withdrawal symptoms when the substance is not used. In the past, we sort of looked at, we talked about dependence. We had sort of different categories for describing this. We've now sort of combined it all under the same header. We don't have like dependence as a standalone diagnosis anymore. We say that if you're having any of these, 2 to 3 of these equals a mild use disorder, 4 to 5 is a moderate use disorder, and if you have 6 or more of these symptoms in the previous year, then you would be considered having a severe use disorder. Right. Okay. And so we'll talk a little bit now about intoxication with stimulants. So when you first like take a, initial dose or a small dose of a stimulant, the initial effects you're having are more wakefulness, more attention, you may be more vigilant. And that's sort of considered like a cognitive enhancement. And that's some of the reasons people use things like caffeine, nicotine, why people chew coca leaves in places at work cocaine is derived from coca leaves and the natural product. There's other synthetic forms of making it, but it has these effects at like low doses, and that's why, you know, they're generally desirable, right? You feel more awake, more alert, you're able to get things done. And so, you know, there's long histories of these being used in like military populations and on assembly lines and things, like encouraged use of not necessarily cocaine, but like coca leaves or other things where nicotine and caffeine in order to enhance workers' productivity. What happens if you are continuing to increase the dose is you're seeing increased muscle movements. People are like restless, they want to move, their muscles want to move. And then it starts to become more of a cognitive deficit. So you start to have manic symptoms, you can have psychosis, people are often confused. And then if you use too much, you can end up in coma or circulatory collapse. So like blood pressure collapsing, heart rate becoming so high that it can't support blood flow through the body. And that's when we, you know, that's a medical emergency and when we really need to intervene. But, you know, we sort of start out like similarly with alcohol, and maybe you feel more relaxed, more social. And then as you continue to drink, you start to have more confusion, you become, what's the word I'm trying to say? I want to say ataxia, but I want to say like you become clumsy, that kind of thing. So, all right. And then in withdrawal, what we see, and this is where I think we were talking a little bit about withdrawal before. So this is a real condition. I think sometimes because it's not maybe as dangerous as like a alcohol or benzodiazepine withdrawal, where someone could, where it could be fatal if someone is withdrawing without treatment. Stimulant withdrawal is still very uncomfortable and painful. So it's a real condition. It can, you know, benefit from some treatment or at least supportive care. So what's happening is you're getting the drop in dopamine. You want to assess for safety for patients. Really, suicidal ideation is common in the withdrawal period, and so you want to be checking for that if they're in your care. Depressive symptoms are really common, and we start to see in the first week is sort of the peak of these. Like people feel really anhedonic, like they just don't care about anything, nothing feels good, they don't have pleasure from anything, they might feel irritable or anxious. You can also have some like physical discomfort, so like muscle and joint aches. They're likely to sleep more, and oftentimes that's because sleep is decreased when using stimulants, and so people then are sort of crashing and sleeping a lot more after use. They're often have poor concentration, they might be craving the substance. After 2 to 3 weeks, symptoms are starting to resolve, mood is starting to improve. But up till 6 months, you can have some levels of cognitive dysfunction, some levels of like cognitive dullness. So feeling kind of like blah, or like you still aren't enjoying things or having as much pleasure as you used to. Depressive and anxiety symptoms can continue. And that's really where we want to make sure we're treating those kind of symptoms if they're lasting this long. Those are often drivers of using again. And people may continue to have a craving for the substance, even outside of, oftentimes we think that they should go away after, you know, a week or so, but they can last many months. All right, so how do we assess and manage patients? So this is just looking at some of the many ways in which stimulants affect the body. So there are risks to our GI system. You can have ulceration in your stomach. You can have ruptures of ulcerations, and those are really dangerous. That's a medical emergency. People often have a lack of appetite, and if they're not eating well or eating enough, they can have signs of malnutrition, like vitamin deficiencies, if their eating is really irregular, especially if they're using consistently for several days or weeks and not eating well. Cardiovascular risk, so people can develop, even if it's short-term hypertension, that can be, you know, such high blood pressures that it can be dangerous. hyperthermia. So oftentimes the cardiovascular system is working so hard and the muscles are working so hard that people can have temperatures that are unsafe and they need to be cooled physically. Heart attack can happen. You can have just arrhythmias in your heart from what's happening is vasoconstriction happens from the stimulants. And so as we're not getting enough blood, our muscles start to, and our hearts start to beat irregularly. You can have stroke and seizure. There's an increased, there's some risk from like actually how you're using. So if you're snorting, there can be loss of smell. You can have like damage to the receptors in our nose that allow for smell. People often can have issues with their nasal septum. You may have seen some patients who have like deterioration of their nasal septum and lose some of their structure in their nose. That's usually pretty like a long-standing, it takes a while to do that, but it can happen. If people are smoking, then there can be exacerbations of lung diseases or asthma. If they are injecting, there's always risks of hepatitis C, HIV, or other bloodborne illnesses, and then even just skin infections or cellulitis at the site where someone might be injecting. And then certain additives to drugs can also lead to an increase in the skin infections. Many of the additives vasoconstrict even more, and so people lose blood supply to the area that they're injecting into, and then it leads to an increased risk of infection because blood usually sort of clears that out of the area. There's an increased risk for overdose from both stimulants and combinations with other drugs. And we see more and more that people who maybe only use stimulants are showing like positive fentanyl drug screens, and they did not think that they had used that. They didn't know that they were using it. And that is what we think is leading to some of that spike in overdose deaths, that people who are naive to opioids, who are then using it accidentally in their stimulant supply, don't have any tolerance, and they're experiencing the respiratory depression from those really strong opioids, and that's causing deaths. There are some like neurological or movement disorders that can happen from long-term use. And then in pregnant patients, because of the vasoconstriction, that can lead to preterm delivery. You can have placental abruption, which means the baby kind of tears off of the placenta, and then the placenta tears off of the uterus, and that can lead to bleeding and a risk of early delivery. And there's hypertensive disorders like preeclampsia and things that exist in pregnancy, and that can be increased risk with stimulant use. And then in terms of our psychiatric complications, so we talked a little bit about like why people use increased energy, alertness, euphoria. People use drugs for performance enhancement, recreation, for sexual enhancement. But the negative effects, we've talked about some of these as well, can be dysphoric mood, increased irritability. They have higher risk of underlying psychiatric disorders. And generally, though, we will diagnose, so we talked about this a little bit too, but we'll sort of say, we might call something a substance-induced disorder for the first month. And if symptoms are persisting after a month without the use of the substance, we would say this is a depressive disorder on its own. We would, and we would be treating throughout that time though as well. We wouldn't wait a month to start treatment. All right, so some of the things we see most often with stimulants is stimulant-induced psychosis. So people often feel paranoia. They can have hallucinations and tactile ones. So like feeling like hallucinations like your skin is crawling, bugs under your skin. Those are really common symptoms in stimulant-induced psychosis. They're less common in things like schizophrenia or bipolar disorder. So sometimes that might be a sign that this is related to a stimulant, but it doesn't mean you can't have them as well in schizophrenia. Mood disorders, so people often appear to have mania. Their energy is increased, they're not sleeping, their mood may be elevated, they're often having racing thoughts. They can be impulsive or doing things that might be reckless or dangerous. And then depression is more commonly seen kind of in the withdrawal or post-acute withdrawal period. Stimulants can have an induced anxiety and agitation. And then sleep disorders are really common as well, both during stimulant intoxication and in early sobriety. Kind of getting back into regular sleep can take a lot of time. And so it's one of the things I sort of counsel patients about in early sobriety that sleep may be difficult and we may need to work on that for a while to set their expectations that it's not going to be a quick fix. And so you always want to kind of consider like when are substances being used, when are the symptoms showing up in order to kind of tease out what might be causing it. And oftentimes patients may say, well, like this methamphetamine really helps my depression. I don't feel depressed when I'm using it. And I talk to them a lot about how maybe you don't feel that way while you're using it, but how do you feel like a couple, the next day or a couple of days after? Like, is it making it better? Is it making it worse? What would you think about if we, try going a week without it and see how you felt? And it oftentimes people are kind of living in the moment. They want to feel better. They want to feel good. And so they'll, it's hard to sometimes get that perspective, but I think it's always helpful to talk to patients and help them track and see how their symptoms are with and, before, during, and after use. All right, and then one important thing to recognize is overramping. We know a lot about overdose in opioids, and overramping is kind of the equivalent from a stimulant of an overdose. So people have both physical and psychological symptoms. It can be an emergency situation because there can be life-threatening complications like the circulatory collapse that we talked about earlier. And it's usually more unpredictable in an opioid overdose. We kind of know how those go. We have a lot of experience and evidence about how opioid overdoses go. Even in the fentanyl era, we understand that opioids, certain ones are longer acting, have more of an effect on the body and might need treatment for a longer period of time. But stimulant overdoses can be more unpredictable, often because we don't know as much about the type of stimulant that someone might be using or where it's coming from, the purity, that kind of thing. And people can kind of experience different levels and symptoms within an overramping episode. So what should you do if you see someone who you think is experiencing overramping? Some of the basics of anything, you want to assess the scene and make sure it's safe both for that person and for you if you're intervening. Don't put yourself in a dangerous situation as well. If you can, if it's safe to, you want to assess the person, check for breathing, check for a pulse, call 911. This person needs to go to the hospital for treatment. And then attempt to de-escalate the patient verbally if you can, and stay with them until help arrives, if that's safe for you. And if they become unresponsive, then you should start CPR. All right, some of the features that happen are related to increased sympathetic nervous system activity and then neuropsychiatric agitation. So people may be agitated, they may be paranoid, they may be experiencing signs of psychosis, so like hallucinations or delusions related to the situation that they're perceiving. Increased heart rate, high blood pressure, high temperature, they can have chest pain, and they can have the cardiac arrhythmias. Seizures can also happen, and then rhabdomyolysis is a breakdown of muscles. As your body is really ramped up and working hard, your muscles start to break down. And that can lead to like overwhelm in your system for especially your kidneys trying to excrete the extra muscle breakdown products. And so people can experience rhabdomyolysis, which is a medical emergency. Oftentimes people need like fluids and interventions to treat that and to monitor their kidney function. Yes.
In the previous slide about respond,
Mhm.
I think one of the discussions we had in our community is to also administer Narcan because of having so often.
Yeah, no, that's a good point.
There,
Yeah.
that-
If someone becomes unresponsive, I always say to give Narcan. It's really not going to hurt. And if they're having an opiate overdose, it will probably help, right? So it's not on the slide, but it's a very good point. And then did someone in the back have a question as well? Same thing? Okay, yeah. Yeah, thank you guys. I should fix that.
You see, I've been seeing a lot of the rhabdo,
Mhm.
and the psychosis.
Yeah. Yeah, oftentimes patients will, end up in a psychiatric unit, and you think about that half-life of methamphetamine, 10 to 12 hours. That's just the half-life. So it's staying around, for several days, and you can still have these symptoms for several days, whereas someone experiencing the symptoms from cocaine may clear a little faster because it's acting for less time in the body. So really, this is more commonly seen in methamphetamine, these issues.
What's the moms look
You won't like necessarily see it. It's like usually we know it from lab markers, but organ dysfunction. So people will have kidney and liver abnormalities, and but I don't know. They might they're going to have some of those symptoms of like potentially they're going to have rapid heart rate. They might have a higher temperature, things like that. But again, it'd probably be checking all that in a medical setting versus seeing it in the community. Yeah. Yeah. So someone collapsing, maybe like a sign in the community that they're progressing that stage. Okay. So immediate responses. So we want to create safety and de-escalate. So this is kind of thinking about like in the hospital now. We've gotten this person into the hospital. Low stimulus environment. So we want dim lights, a quiet room if possible. Verbal de-escalation when possible. And I do emergency room psychiatric and addiction evaluations and hospital psychiatric evaluations. And I see this is where verbal de-escalation is tough sometimes, and people are not well trained in it. And oftentimes their attempts go the opposite way to escalation, right? And so this, I think, is an important thing to train in emergency settings. You want to talk quietly to someone. You're not meeting the same level if they're feeling paranoid and angry. You're not meeting them with that same energy. You want to be a calm, quiet, person who's reminding them that they're in a safe space, that we want to just, we want to take care of you. We're here to help. We want you to be safe. We want you to be relaxed. Like, can I bring you a cup of water? Just trying to do some interventions that may help if it's not the right time to get labs right away or try to get a urine sample or something. You can try to calm someone. And you want to avoid confronting people, as paranoia and fear are pretty common. And so trying to give a little space while also initiating treatment. It's a difficult balance, but I've seen it go really well and I've seen it go really poorly. So, oh, sorry, I didn't change the slide. There we go. All right, so first line medications, we want to treat with benzodiazepines. I don't love benzos. I don't usually prescribe them, but in this setting, this is our go-to. It's going to help to decrease agitation and decrease blood pressure and heart rate. And those are really important things we want to get under control. It can also prevent or treat seizures, and it can help to lower or prevent the escalation of high body temperatures. And so these are some options here of dosing, but we'll kind of skip this. But the nice thing about them is they can also be given as IV medications or intramuscular medications for quick administration, even in someone who's really agitated that we want to try to get calmer so that we can start treatment for them. Second line is we want to do antipsychotics if they're experiencing psychotic symptoms. We want to do this after benzodiazepines. One of the side effects of antipsychotic medications like Haldol, Risperidol, Zyprexa, things like that, is that they can have muscle movement abnormalities, and increasing muscle movement in someone who already has an excess level of muscle movement could worsen some of the symptoms. So we want to do these after giving benzos if possible. They can also lower seizure thresholds, so we want to avoid that. But I do see a lot of times where these are the medications given first instead of the benzos. So it's always good to check your ED and see what their practices are and kind of educate on benzos first. And then hyperthermia management may include like cooling devices, so using ice packs or cooling blankets, giving IV fluids. Things like Tylenol or medicines to bring down a fever aren't going to work, but benzos could be helpful. And then if someone is to the point where they're at 104 degrees or higher, they're going to need to go to the ICU usually, because that's a life-threatening emergency. And then we want to monitor their hearts because of the potential for heart attack. And then rhythm issues, and then, treating for the agitation and treating for chest pain can be helpful. Avoiding things like beta blockers on their own, because stimulants vasoconstrict through alpha receptors. Beta blockers are kind of the opposite, and they can basically like increase the effects of the vasoconstriction if we give those on their own. Again, benzos first if there's a seizure, and then phenobarbital or the ICU if their seizures are not improving. Here's some labs that we'd want to check for folks to monitor how they're doing and look for signs of rhabdomyolysis and heart attack. I'll kind of skip this since it's not so much of a medical audience. And then when we would want to admit to the ICU is if they have these conditions, but I'll kind of skip through this. What we don't want to do is argue or try to aggressively, like convince people that they shouldn't be paranoid or that their hallucinations aren't real. This isn't the time for that. It really usually never is, but definitely not in this moment. We don't want to delay medications waiting for labs. And so sometimes people will say, well, I think, I've talked to ED providers who are like, well, they just look psychotic to me, but if there's a chance, if they're having these other physical symptoms, I say that's not psychosis. They don't, your blood pressure isn't high, your heart rate isn't necessarily high just from that alone. And so let's just treat them as if this is something else, even if we don't have labs back, or if it's a patient who has a history of stimulants in their drug screen, then I think it's important to just treat and then, kind of figure out later. And that way we're avoiding potential complications. All right, and then when someone's stable in the ED, this is where we want to bring in other resources in our community partners. So doing brief interventions with like peer supports or social work, or sometimes nursing, whatever your system does in terms of an intervention around substance use. Talking to someone about treatment options if that's something that they're interested in. Even just giving referral to services or having a conversation. If there's a consult team, that's wonderful. Counsel patients just on how to promote health. So making sure they're staying hydrated even while they're using, that they're resting, that they're checking their drug supply for other things in it to make sure they know what they're using, to avoid using things in combination if they can avoid it, and to start low, go slow. So instead of, just starting with high doses of things that can lead to these kind of episodes, advising them to try smaller doses, and wait some time in between uses to help to avoid this. And then if people are having, there's concerns for suicidality, or they're talking about harming someone else, or their psychiatric symptoms are persisting, then that would be a good time for a psych consult or considering an admission to treat those symptoms as well. And then we'll talk a little bit about some other health promotion things for people who use stimulants. So, yeah, oh yes.
So that was like getting them through their ovary.
Yes, so they're like through the medical crisis, yeah.
His term with prescription.
Right, no, this is thinking all hospital treatment, yeah. Yeah.
So we.
Clinic, yes, yeah. So then some other things for health promotion, and this slide, and then in 2 slides, we kind of talk about some of these other things, like if they are going home, what could we help them with? So talking to them about ways to reduce skin and soft tissue infections. So options for clean syringes and supplies, ways to prevent infection, how to prevent accidental opioid overdoses, prescribing naloxone for them, making sure they know how to use it, and always making sure that if it's great if they know how to use it, but if they're going to be using something, we want someone that they're with to know how to use it. So I always ask patients, who do you use with, or who would be around you when you're using, and do they know how to use this so that they can give it to you, because you're not going to be able to give it to yourself. Or things like hotlines, so people can call and talk to someone on the phone. They give their location while they're using, and then if they stop responding for a certain amount of time, that person on the phone sends emergency services out to their location if they're not hearing from them in enough time. So things like that so that patients know how to safely use if they're going to continue to use. And so we'll go into kind of like the outpatient treatments now, switching over to that. So this is another like universal treatment considerations. So things like educating on overramping prevention, talking about opioid overdose, prescribing naloxone, and then chill packs. This is something that sometimes gets prescribed. I don't see this happen a lot, but you could consider like a few doses of an antipsychotic so that if they are using and starting to experience paranoia or psychosis, they could take a dose to help calm down. You want to kind of, be careful in prescribing if it's someone who has never taken these medications, or, if there's a risk of suicidality, you don't want to give them so much that they could hurt themselves with it, but like 2 or 3 doses of a medication to help them to calm down is probably a safe option. And then things like considering HIV prevention if someone is at risk of HIV transmission with PrEP or PrEP would be something to think about too. All right, so then the general rules of management. We have a number of behavioral therapies that help with stimulant use disorders. The kind of gold standard in treatment is contingency management. I understand there are some contingency management programs in the area. Is that right? Yeah. They're often kind of resource intensive to operate because they're based on rewarding people with like monetary items or items of some value for like usually a negative urine drug screen for what a stimulant. And so that can be difficult to maintain, motivating rewards for people coming into a program. One good thing is in 2025, so SAMHSA had previously had a restriction on how much you could spend on a reward for a contingency management program of $75 per year, which is like really not effective. And they increased that to $750 per year. So you could give someone like a $5 to $10 gift card if they, to like a restaurant or something like that, if they are, meeting the requirements of the program with negative screening or attending appointments, and that can be motivating to continue people in sobriety and engagement or treatment. While there are no FDA approved medications, there are medications with indications and good research showing that they can be helpful in stimulant use disorders, and we'll go through a bunch of those. Cognitive behavioral therapies, engaging in intensive outpatient programs, partial hospitalization programs, things like that can all be really helpful in helping people to find other healthy ways of not using, dealing with stressors, engaging in sober communities, engaging in support like that. So we'll kind of focus a little bit on some of these medications that are available. And the other thing you want to do is treat other illnesses, especially like mental health conditions, because we know when one thing goes untreated, the other often does as well. So treating depression, anxiety, underlying psychotic symptoms so that patients are feeling well enough to engage in recovery. All right. So the next set of like few slides is based on the American Society of Addiction Medicine and the American Academy of Addiction Psychiatry guidelines. So they came out with these, I believe, in 2023. This is like a little handbook that has like an overview of this very intensive guideline, but it has a lot of great tips and information. I have a few of these. If people are interested, you can also order other ones. But we'll kind of talk through some of the guidelines here. So this guideline was created to assist clinicians in providing evidence-based treatment for stimulant use disorder and related conditions, and in attempts to prevent harms associated with use. As we know, stimulant deaths are increasing, and so are long-term health consequences from use, and we want to be able to address this health crisis. All right, so first is, identifying any urgent medical or psychiatric needs, and then referring patients to appropriate treatment. So, if people appear to have infections or, there's skin conditions or cardiac issues when they're coming into your clinic, you want to make sure that we're getting them the help they need to address all their health issues. You want to do a comprehensive assessment, understanding, what they're using, how they're using it, whether they're meeting criteria for a use disorder, obtaining labs, and then if there's risk for like heavy or chronic use, if you might want to check their heart with like an electrocardiogram, or some other, check for kidney function issues if we're suspecting that their use could be leading to other medical issues. And then thinking about treating patients. So like I said, we don't have any, I wish we had like methadone or Suboxone to offer for stimulant use. We do not have that medication. We have a few things that have shown some benefit. So for methamphetamine use disorder, there was a study in, I believe, 2021 that showed bupropion or Wellbutrin at 450 milligrams plus Vivitrol had the same benefit in reducing methamphetamine use as Vivitrol does in alcohol use. And so very effective, not 100%, but it can be helpful. The biggest problem here is that it's hard to get Vivitrol approved by insurance for methamphetamine use, and it's very expensive. So until that's off patent, it's not the most easily accessible medication. But if someone also has an alcohol use disorder, I have gotten it approved by insurance for that reason, and then we're treating both their stimulant and their alcohol use disorder. And then you can prescribe it along with the bupropion, and that is shown to be helpful. Both medications, bupropion on its own has shown some benefit as well. So Wellbutrin on its own has kind of a similar like dopamine effect at a much lower level, but it has shown benefit in helping with reducing cravings and then use of stimulants. Long-acting injectable antipsychotics can help in reducing use. Often that's the case where ongoing psychiatric symptoms and psychotic symptoms are kind of driving use, or people are having the symptoms from use and then kind of continuing to use. And so oftentimes those are helpful. And then Remeron or mirtazapine has shown to be helpful as well. It's not really clear why, but several studies have shown that it can be helpful. One thing that it can do is help with sleep. And so there is some potential that improving sleep and then it helps with depression might be helping some of the reasons that people might be motivated to use. And so that's sort of the theory, but we're not totally sure. And then there is evidence that long-acting stimulants like things like methylphenidate extended release or amphetamine extended release can be helpful for patients with methamphetamine use disorder. But the recommendations really say that they should only be prescribed by kind of experienced clinicians who have experience treating addiction and are comfortable with sort of the additional monitoring that you would likely want to do if you're prescribing a stimulant to someone with a stimulant use disorder. Including things like frequent visits, checking pill counts, doing drug screens that would look at, because you can tell if they're taking like Adderall versus methamphetamine. So you'd want to kind of do some of that checking to make sure you're not increasing risk by giving them a stimulant on top of ongoing stimulant use. But that is something to be considered. For cocaine, again, no FDA prescribed or approved medications, but again, bupropion is seen to be helpful. And then topiramate or Topamax has shown benefit. It helps with cravings. It, however, is sometimes called Dopamax by patients because it makes you feel kind of cognitively like dull and slow and people feel a little foggy. So I have had a lot of success in using this with cocaine use disorder. And what I usually do is give people like a low dose at night so they sleep through some of those side effects. And then we start to increase the dose when they're a little more used to it. I have this case that I always tell people about. I think she was like 53. She's, early 50s. She was coming to a methadone clinic. She had been in treatment for like 15 years. All throughout the time she was in the methadone clinic, she would have cocaine positive urines in usually every other week, every week for a while, a couple times a month or something. And we were talking, it was my first time seeing her, and she was struggling with depression. And so we were talking about that and starting a treatment. And then I said, how's your cocaine use? And she was like, oh, I don't use that much. It's really not a big deal. And I just sort of said, well, what I'm seeing here is it looks like you're using pretty regularly. Can I show you what my screen shows? And I just showed her the drug. She's like, I cannot believe it's looking like that. She's like, it looks so bad. I don't think I use that much. And I said, well, have you ever considered a medication for it? And she's like, well, I didn't think there were any. Like, I'm on methadone. There's nothing like that. I said, there isn't, but topiramate can be helpful. We could try it. And so over a course of a few months, we got her on this medication, increased the dose, and her drug screens went to like once every like 2 or 3 months, she would have a cocaine positive. And she, it was like a hard thing to give up totally. It was like her friends would use it. It was like she felt really good when she'd have fun at a party. And really her risk was so low at that point that, we talked about her cardiac health because that was one concern of any ongoing use. But she said, I can't believe no one ever told me about this. And I'm like, yeah, like people don't offer treatment for stimulant use, but there are things that can be effective. So, she was in a methadone clinic, she was getting substance use treatment for a long time, and like no one had ever talked to her about this. And I was a resident, so I was like all gung ho, like there's this treatment I heard about, let me offer it, let me see what happens. And I offered to other people who were like, I don't want to take that. But it was a very powerful moment. And it's one of those things where I often hear the sentiment that like these conditions can't be treated, there's nothing we can offer. And I really just don't think that's true. We don't have any magic bullets. We don't have that really for anything though. Even, Suboxone and methadone aren't 100% effective. And so we have some things and we have things that can be helpful. And I think we should be trying to offer those.
I wonder if that's because Medicaid doesn't pay for.
She's on Medicaid in Maryland and it paid for that.
Medicaid pays for.
Yeah. Yeah. And so sometimes because they're not FDA approved, that can be harder to get coverage for them from insurance companies. But I have found topiramate also has like a number of indications, like you can use it for headaches, it can be used for seizures, it can be used for mood. And so you can, she had a depressive disorder. So, if they asked me, I would have just said, well, it's because she's depressed and it's helping. So, but you're right, that is oftentimes a barrier.
These are very common for these
Yeah, most of these are also old, like they've been around, there's generics, so they tend to be lower cost. So a lot of these Vivitrol is the one that's like often hard to get covered because that's expensive and newer, but you're right.
It is, but I've rarely seen use.
Yeah. Yeah.
So is that something studies, is that something that is being looked at or is it not considered a high priority?
Yeah, so what's hard about FDA approval is that the drug maker would have to go through the process of getting FDA approval. So even if we had like 100 studies and they were all like, this works so well, the FDA isn't going to just say, okay, it's approved. The drug company has to say, we're going for FDA approval. It's pretty expensive. It's a lengthy process. And if they don't think that the medication is going to make them a bunch of money by being prescribed for something, they often don't pursue it. So a lot of medications that we use are non-FDA approved for the reasons that we use them. Like I'm, a psychiatrist, I give Seroquel and Trazodone for sleep all the time. They're not FDA approved for that. Half the things I do are not FDA approved for that. Sometimes people are like, what's this FDA approved? Like, I don't even know. I know that I use it for this, but like, what are all the FDA indications? I couldn't really tell you, but it's because it's such a laborious and expensive process. Most drug companies don't pursue it if they don't think it's going to be a benefit to them. And that's a big problem, right? Because then insurance companies follow suit and they say, well, we're not going to cover it because it's not FDA approved. It's not a good system. Yeah. So I'll say that. But like most of pediatrics is like using non-FDA approved things because we don't do a lot of studies in children. And so like almost everything that we do in pediatrics is kind of a generalization from the adult studies to, well, it'll probably be okay in kids. We'll just change the dose and we'll do it based on weight and things like that. And so I think that's always something to consider when you're hearing the argument that there isn't anything FDA approved is like, a lot of what we do in medicine is not FDA approved. So
would these same things, be appropriate for teens?
Generally, yeah, I would consider I would look at dosing for teens. Most teens you can do adult dosing with, but occasionally, like if I have a smaller or like a underweight teen, I would consider just lowering doses of things. There aren't a lot of studies. We don't study addiction that well in teenagers or looking at treatments because it's hard to get the consents and the approvals to those kind of things. But obviously, I would say in terms of best interventions is we would treat a kid with a stimulant use disorder versus not, and because,
Same way.
yeah, because there's depression maybe going on or other things, like a lot of these medications could be justified as treating depression. And so sometimes we're looking at, I think we'll talk about this in a couple of slides here. So let me just skip down. So this is just an overview, but so this is some of the things to consider. So like someone with a cocaine use disorder and depressive disorders, Wellbutrin might be a good option because it can treat both. And then it's easier to get approved if there's an insurance issue. The topiramate can be helpful also with alcohol use disorder. So in anyone who has cocaine and alcohol use disorder, consider something like that because it might help with both. In stimulant or methamphetamine or amphetamine type use disorders, the Wellbutrin or bupropion, again, helpful with if there's both depression and amphetamine use. And then if there's alcohol or tobacco use or depression, the combination of the Vivitrol and the Wellbutrin can be helpful. Again, alcohol and methamphetamine use, consider topiramate, and then Remeron if there's also depressive disorder. So this is a way to kind of like, kill two birds with one stone, or, if there's insurance issues or other things like that, consider this. And it's always nice if we can help two things with one medication. So, and then this, we'll kind of skip over, just because, this is kind of talking about like if you're going to prescribe stimulants for stimulant use disorder, but we don't need to go too into detail with that. And then this is kind of an overview of those medications you might give for stimulants. So we'll kind of come back here. So generally we want to try to treat both stimulant and co-occurring disorders if possible. We want to address mental health. We want to offer treatments for like therapies and other things to go along with medications, because that in any substance use disorder, we know that that's going to have the best outcome is psychosocial support in addition to medications. I'm going to kind of skip this because this is about medications. Oh, one thing I will say here, pregnant patients and the ramification of drug screens. Do people see this come up at all? Like having a positive drug screen while pregnant in any other settings? Yeah. Yeah. So this is just something I kind of think is important to say, that like weigh the risks and benefits of getting a drug screen for a patient who's pregnant. Will this help the patient? Will it potentially lead to Child Protective Services being involved? How would that impact both the fetus or the baby and the mother? And make sure you're getting informed consent so they know what the possible ramifications of a test is. And then knowing where you're practicing. So what do your state laws say? What are anything regionally, anything locally that has additional regulations around reporting? Some states require that if you have a positive drug screen, you have to report that to Child and Protective Services. Ohio does not have that, but there are other states that do. And so if you did a drug test, you'd have to call CPS and say, I did a drug test and this person's positive for whatever it is. And that, it can be very difficult in your rapport building with a patient. So something to consider. And then I'm going to kind of skip over this, honestly, because it's not as important. Okay, let's go here.
We do actually have a law. It's called the CARA.
Yeah.
In Ohio, you have to report positive drug screens.
Do we have to?
Yeah.
So there you go. Good to know.
It could
What do
go
people
wrong.
here
It's a
do?
little
Yeah. Yeah.
state law. If the Medicaid, if it's not prescribed, if it's like, abused or misused or non-prescription.
Yeah.
And it is mandated reports, but if a patient is just on medication, that could cause withdrawal within the baby.
Mhm.
It does not. Not, or if it is.
Yeah.
prescribed.
That's interesting because my hospital didn't, the last hospital I was working in, I did not do that. So,
It's
okay, maybe I was working there though. So I don't know. I won't tell them that they're not following state law. But no, I think that's a really good you know, reminder to consider why you're getting it and what it's, you know, what will happen if you do. All right, so then behavioral health interventions that are helpful in stimulant use that, you know, should always be offered and go along with treatment. Oh, sorry. There we go. Here we go. So things like cognitive behavioral therapy, motivational interviewing, community reinforcement approaches, matrix models, and then exercise supported recovery are some other models of treatment that can be helpful in stimulant use disorders. And then I think that is all of my talking points, and I was about an hour and 15 minutes. So I would love to hear from you guys, like what sort of things are you seeing? Are there cases, questions you have? Yeah.
I just have a question. I just recently got out of an inpatient and they don't even put you in detox for stimulation. Like,
Yeah.
You know what I mean? Like they took
Yeah.
me right in residential plan. Like I had to start going to groups right away and you know what I mean?
Mhm.
Like, they didn't check on me. You know what I mean? I didn't get no withdrawal meds. You know what I mean?
Yeah,
And
yeah.
I am pregnant. So
Okay.
you know what I mean? So like it's just, they say they don't do it for cocaine or meth or, you know what I mean? And I see it with everybody else that came in too, so.
Yeah.
It's just,
Yeah, I think there really is an under recognition of kind of how difficult withdrawal can feel. Insurance won't pay for a stimulant withdrawal in a hospital setting. I think that's probably the biggest reason that they don't do it, but that doesn't mean that like there shouldn't be some consideration that, especially if someone's like in a treatment program for like the early, you know, few days after getting there, that it's gonna be harder to attend groups, that you're, you know, gonna be more tired, like all those things. So yeah, that's a great point. Yeah. Yeah.
I think what I see a lot with like the stigma with stimulants is kind of similar to like mental health. Like, you know, when you would have withdrawal from like opioids, you have the physical withdrawal, like people can see the
Yeah.
withdrawal of that. But with stimulants, it's like it is a lot of like internal and a lot of like, you know,
Psychological symptoms, yeah.
I
Can't see.
think people can't see it. It's like it just doesn't exist,
Mhm.
you know, it does.
Yeah.
I think, you know, most patients that I work with that, you know, have withdrawal, it is those cravings and thoughts. It is the, you know, not being able to function.
Mhm.
When we do see patients, you know, they sleep for like 5 days straight and don't wake up and eat or drink or anything.
Yeah.
It's I mean, withdrawal is real with
Mhm.
stimulants. And I think a lot of times you can't see the physical
Yeah.
aspect of it. A lot of people believe it doesn't exist, but it
Yeah.
really-
And if someone's sleeping, they're not, they're quiet and calm, right? Like, so it's kind of more ignored, right? We're not like paying as much attention to it as compared to someone who's like, you know, in alcohol withdrawal and they're delirious and yelling and hallucinating, or opioid withdrawal and they're terribly sick and they're vomiting and having diarrhea, you know, like that, those look very different, right? And so it is easier to ignore, even though we shouldn't. We should really be taking care of patients. And really it could be supportive therapies, you know, like things to help with any kind of like, you know, even it's just like some medications to help with pain for muscle and joint aches, or letting them rest in a comfortable environment, and, you know, encouraging hydration and food, things like that while they're getting through that.
And a lot of us on our mental health meds when we go in there, you know what I mean? So like then
Restarting those, or
restarting
yeah.
those, you know what I
Mhm.
mean? Like we just don't get the time and the, you know what I mean, the attention really
Yeah.
that I feel like is needed because of it just being a stimulant, you know what I
Mhm.
mean? So
Mhm.
like me, you know, going in after using for, you know, a couple of months straight every day, all day long. Like my anxiety is high, you know what I mean? Like you say, like I get those muscle spasms, like, you know what I mean? And it's just, I don't know, I just feel like it's very, very overlooked. And
Yeah.
it's, you know what I mean? It's hard. It's
Yeah.
hard to go in there because then, you know what I mean? You're not getting really what you need until
Yep.
you get past those.
Yeah, I think it's a really important thing, like you bring up, like, why would someone come into treatment? Yeah. if they're not gonna feel like they're getting helped for the things they really need, especially like those immediate kind of physical and psychological needs. Thanks for sharing that.
So like, we know, like how we talked about earlier, like Narcan being used, is there any drugs like Narcan for stimulant use?
No, there's no like antidote. It's
Okay.
you just kind of have to wait for it to like be metabolized out of the system. Yeah. So we don't have something that will reverse it. Yeah. The only things we really have are Narcan for opioids and a medicine called flumazenil for benzos, which isn't used a lot because it can induce seizures if you use it. But we don't, yeah, Narcan is kind of great, but we don't have a lot of other
Yeah.
other things like that. Yeah. Kratom? Yeah. So it's technically like not illegal, right? So it's sold at a lot of shops and it's advertised for. It's a weak opioid and a weak stimulant. So it acts kind of in both ways. So I've seen people having stimulant like effects and having some like psychotic like symptoms. And then I've had people experience opioid withdrawal when they stop using it or are using it for opioid cessation. I think it's sometimes billed as like you can get off of fentanyl with this, but then people continue to have opioid withdrawal effects from it.
So it is addictive.
It is addictive. It develops a dependence similar to opioid use. It's just not it's not going to be as like overt as like fentanyl is because it's just a much stronger substance. But I definitely think the selling of it and the way it's being like, promoted as like a plant, it's healthy, like I don't think people understand that it has opioid effects and potentially stimulant effects. Like I saw a patient just the other day who broke his own arm in the emergency department while intoxicated with kratom. Had to go to surgery but I was just like, they were like, his drug screen is negative. I was like, this is something, And then his mother came in and said he keeps using kratom and like I keep trying to get it out of the house. And but eventually, that is what we thought was going on was that he had used a lot of kratom. And I mean, it's hard to fracture your own bone. So he was very sick. And then, they were like, he's ripping stuff off the walls. He is so psychotic. And I was like, it isn't like adding up to me because like 2 days ago he was fine. And so, we were like, I think there's a substance involved. It's just we're not something we don't test for, but it ended up being kratom. And then like several days later, he was doing great and calm and cooperative and yeah. There's one back there and then we'll go. For kratom, I have used Suboxone for kratom. Usually, people don't need as like high doses as they do for fentanyl use, but I've done like 4 to 8 milligrams, and that's usually pretty helpful for opioid cravings and withdrawal symptoms. Sometimes people like just want a short term or a taper with it, and then some people stay on it longer, but I kind of let them dictate how they want treatment to go, but usually 8 milligrams is the highest I've needed to go if it's just kratom use.
Were you able, so prescribing it for kratom use, did you run into any like prior authorizations or issues with like?
It was in the hospital and I didn't, and so I don't know if they had any issues in the community. So that's a very good question. Yeah, if there was any trouble getting that covered.
I think that's what the concern is in the community, in the
Mhm.
hospital, hospital environments, there is no questioning as to what you prescribed the prior authorization.
Right.
time.
Yeah.
But then it's the
Continuation, yeah.
application in the pharmacies and stuff like that. So I think that's why there's been a lot of, not a lot of treatment for kratom within our community because of the outpatient ability for patients to be able to obtain the medication.
Yeah, it would be sometimes I've called insurance companies directly and just like asked or talked to Medicaid at the state level to see like what they would cover. And if there's any other indication, like even if it's pain or if there's an opioid use disorder in the past, you might be able to get it covered through that. But it would be, and maybe even something to advocate for coverage for that reason. Because I think we're seeing a lot more of it. And oftentimes you don't know if you don't ask oftentimes because it's not on a drug screen. And so I think it's always important when you're doing a history of substance use, that you're asking about other things too, you know, beyond just stimulants and alcohol and opioids, that you're asking about synthetic cannabinoids like K2 and spice, that you're asking about kratom, that you're asking about. Somebody just say, do you ever go into like a head shop and buy anything there? Do you ever go online and buy anything there? Like, what do you think that is, or what do you know it to be? So, yeah.
So like with a UPS, does like the Mayo Clinic or anybody test for kratom? Cause I know we get some cars sent out.
Yeah. The only places I really know testing for regularly are like the coroner's office, because they do those kind of crazy tests if someone has passed, if they're looking, especially to see like if there was an overdose. I don't know. That's a good question. There might be some labs that will do it with a send out. I'd look at one, whether they'll do it, how long it takes to get back, and then the cost, because it's usually something that's going to be out of pocket, and you want to know how much it's going to run the patient to do that. And then, and it, you know, sometimes with drug testing, I'm like, if you're this unwilling to tell me, what is the point of me testing you, right? Like, if we can't have a conversation about it for me to help, then like, you know, what am I like, gotcha, you know, I knew it. So, you know, I think what you want to do is build a relationship with a patient who will tell you what they're using so that you can help. And, you know, if they aren't ready to come to you and tell you what they're using, then it's oftentimes really hard to progress in treatment anyway, you know.
So it does take, we don't run for everybody, it does take talk, I mean, either, you know, concern for it, or, I mean, honestly, my experience with creating most of them, we're pretty upfront about it.
Mhm.
Saying, don't have any issue, so they're not that.
Do you know what that costs for them, or? Yeah, it's not a super expensive thing. Okay, that's good.
Like probation and the courts, they do have cops that do have instant with like freight.
Okay. Yeah.
What do you do now?
What do I do now? About 9 months ago, I transitioned to being full telehealth, but I was previously the director for addiction treatment at Cuyahoga County Jail. And I did that for about 4 years. And then now I do telepsych to Nebraska and Iowa. And we're working on building an addiction consult service. So we cover about 17 hospitals across those two states, and do emergency department and hospital consults. And we're trying to build out an addiction service. So I sit in my basement in Ohio, and I see patients in Nebraska and Iowa. So it's kind of random, but that's how life worked out. And I do this stuff because I think it's fun to still be like in person and get out in the community.
I know we don't know, I don't think I see any prescribers, and I know you're gonna be doing this with me, but each week, I believe is it weekly, the check-in on the online kind of support that they have
Through Oren.
Yeah.
Yeah, I think it is weekly. There's like groups that they run. I don't get all the emails about those, but I'm pretty sure that they are weekly. They have like a different one for the consultants, so I don't always see the community ones. But there's also things like PCSS, the Provider Clinical Support Network. Can I get on the internet on this computer? Because I could just pull it up to show people. I'll let you do this so I don't mess up the recording. But there are a lot of great webinars and resources there. You know, some of them they're kind of geared towards prescribers because it's the provider clinical support system, but they have like just a wealth of like all kinds of levels of education around substance use. They also have mentorship. So if a clinician is looking for some additional guidance or help in starting treatment for substance use disorders, they can be paired with like a one-to-one mentor who can answer questions for them, or they can review, you know, cases or things that come up as they're seeing patients. So this is a really nice tool. So I would encourage people to check it out. Some of it is just like 101s, like, you know, similar to what I talked about today with stimulant use disorder, about all kinds of different substances and different treatment types. There's a lot of stuff on like therapies, if anyone wants to review those. And it's just like a nice resource. It's free, and then the mentoring is free as well. And then American Society of Addiction Medicine and the American Academy of Addiction Psychiatry both have like educational resources available. And then Opioid Response Network itself has some, I believe there's some educational resources like on the main website too. So, I think the goal really is we know that education about substance use disorders is really poor in medical training, unfortunately. And this is a way to kind of bolster some of that so that clinicians can offer treatment and feel like educated and supported in what they're doing in the community. I think there's across the country, I think there's like 3,000 board certified addiction psychiatrists and maybe like 10,000 addiction medicine doctors because they can come from a lot of specialties, but that's not enough to treat all the patients who need help with substance use disorders. And then sometimes in rural communities, it's even harder to find a specialist who's trained. So these are some ways to get additional training. And then for anyone who's like working with prescribers, the DEA now requires for you to have a DEA license that you do 8 hours of training in substance use disorder generally, and this offers a free training for that. So if anyone who's prescribing, you need to have a DEA to prescribe any kind of controlled substance, and so this provides that free training. So it's a good resource for that too. Anything else people are thinking about or cases or stuff you're dealing with in the community? Maybe you can help each other too. I don't have all the answers, but support one another.
I would just thank myself. My name is Jennifer Loera. I'm the nurse navigator for the MOMS program for Wellington Valley Hospital. I recently, some people had asked me, like, how many women do you have engaged right now? And, my numbers kind of like fluctuate here and there. So I did a really quick kind of like assessment, today, and I have 21 women who are consistently engaged with the MOMS program. And I kind of took a little deeper dive, and within the last 2 months, I have had 8 women relapse on stimulants. Some of them have, engaged in treatment and are, went inpatient or did, other things like that. But, to me, it just opens my eyes that out of 21 women, 8,
Yeah.
With stimulants
Mhm.
is to me, it's concerning. So I'm sure a lot of people in the community are also seeing, the stimulant use within our community also.
Yeah. Any sense of like what might be going on or individual things for each person or something community-wise or yeah.
I just wanna say, I'm one of them, and none of us hang out. The 8 of us hang out, you know what I mean? So it's not like we're engaging and in use together, so it's like, it's really common in the community right now. When I went into inpatient, there were people there for heroin, there's fentanyl, there's people there for crack cocaine and methamphetamines and alcohol. You know what I mean? So like, I really think with the fentanyl being, killing people, which I got clean in 2018 off heroin. And I just never touched it again because it was killing me. I was dying. And then I was clean for like about 6 years. I almost hit my 6-year mark and I relapsed on methamphetamines. And I didn't like it, so I started smoking crack and it just took me under. Like it literally, and now like getting clean off of it, like I think about it 24/7. This has never happened to me. I didn't fight addiction like I did with fentanyl, heroin, you know what I mean? Like this is, it's bad, it's hard, it's super hard, you know what I mean? And there's not a lot of stuff, you know what I mean? I'm on Wellbutrin and I start Vivitrol today, so I'm super excited. Because it does help me.
Yeah, good.
I've expressed, to my care team, over and over again that like that's what helps me stay clean. I work a 12-step program, I'm very engaged into that. But at the same time, like those medicines really do help. They do. As long as you stay on them. Because I like to be a doctor, and once I start smoking, I'm like, oh, I don't need it. You know what I mean? So, and that's when I go and relapse too. So I do, those, it really does help, for cocaine too.
Yeah,
I
yeah.
didn't see the control up there.
They haven't studied it. They just, it doesn't mean it wouldn't help, but they just haven't done a study on it. Yeah,
Yeah.
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 But thanks for sharing these stories,
That's
because
good.
I think, like, I didn't plant you, but I feel like I could have. I feel like, look at treatment, it works.
She was in that. Like, smile.
Yeah, 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 yeah.
It's happening, copy paste.
Yeah. Yeah, and people were really skeptical of the Vivitrol and Wellbutrin study when that first came out, because they were like, oh, well, it's not, going to be that effective. But the study was very smart, because they said then there's a statistical measure called number needed to treat. Like, how many patients do you need to give this treatment for one to stop using the substance? And it's the same number needed to treat as it is for alcohol use disorder. So we've all been like, oh, Vivitrol's pretty good for that. It's not, it's not amazing, but it's pretty good. And to say like, well, it's also the same for this. This is like the one substance that we do not have really great treatments for, and it's as effective as it is for alcohol use disorder. Like, let's give it to people. Like, let's try to get this out there. So, the GLP-1 drugs, like the Ozempic and those things. Yeah. So, they are helpful so far in the studies for alcohol and tobacco is what we've seen a benefit for. They've tried cocaine and it has not been all that effective, unfortunately. Cocaine is like really elusive. Stimulants are just kind of harder, partly because of that, like the mechanism of how much dopamine gets flooded into the brain. But they're continuing to study it to see if there's any other benefits for stimulants. But right now we think we've seen people reduce their alcohol use and their smoking in the studies looking at that. And then they've started to do some opioid ones. I think there's some potential benefit for opioids, but I don't think it's going to be better than methadone or buprenorphine at this point. But hopefully we'll see some benefit for stimulant. It seems, it's like the parts of our brain that are like get lit up by drugs and food and sex and all these things are like kind of related, but like, not exactly. And so, when we see that something might be helpful, and really the only reason they started studying it for alcohol is because people who were taking it for weight loss and for diabetes were drinking less. And they were like, well, I wonder if that means it works for that. And so they've started to look just at people with alcohol use disorder. And it is showing that there's a reduction in overall use, and some people just completely stop drinking. So hopefully that will be another treatment down the road. Yeah.
I did also want to mention, you said something about people going, like, failing drug screens and having fentanyl. I went to inpatient, there was fentanyl, and I did not use it at all.
Yeah.
But it seemed like, I don't know, I say I've been nuts for like a little over a year, on and off. But here recently, like, when I was getting high, I wasn't getting an up feeling. I was getting a down feeling. I
Yeah.
could go to sleep. And
Mhm.
it was, you know what I mean? Like, so there's really fentanyl in
Yeah.
the crack and the cocaine
Yeah.
out here, you know what I mean? It's
Yeah.
scary. It's very.
Yeah, it's very scary. Same, the jail I worked at in Cleveland, we had patients who, if they reported substance use, we'd offer a urine drug screen that was not a part of their criminal record, but for treatment purposes. And I had a lot of patients tell me, no, I'm just using cocaine, I'm just using meth. And well, you were positive for fentanyl. I'm like, there's no way. And I'm like, I can show you the the test right here, but like, so we would talk a lot about naloxone and, like testing their drug supply. We weren't able to give those materials in the jail, but we set up like a vending machine in the lobby so that I'd be like, stop by the vending machine on your way out so that you could grab that stuff. I don't know how many people actually grabbed it, but hopefully enough. So, but yeah, exactly. I think there's a lot of different stuff in the drug supply and it's hard to know. So test strips are really important. And not only like fentanyl, but now we're seeing the nitazines and the xylazine and these different adulterants. And you can get test strips for those as well.
So I have all the.
Okay,
To be clear.
there you go. And now you know where to get them. Perfect.
And
Correct. And we have 5.
Awesome. Yeah, great.
Before get fentanyl, that's what I wanted, but I would test positive for meth, so somebody acting like that.
Okay. Like the opposite, yeah.
Up for days.
Why? Yeah. Yeah, the test strips like mostly look for like the things you're not, we don't have like a meth tester, but, that I'm aware of. They might be out there. Definitely the like cup drug screens you could do that would show positive for it, but like it's not gonna, like dipping your drugs is gonna be a problem. Congratulations. Good. Yeah. 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 Yeah.
Does,
I don't blame
do
you.
the testers test, like you can put it in any drug? know
Yeah,
what I mean?
you can usually,
You cannot, you cannot test stimulants for xylazine. It will always test positive.
oh, I didn't even know that. Okay.
Yeah, you can only test stimulants for fentanyl. And benzodiazepine, yeah.
What about the other one? Oh, that was.
Yeah, the xylazine,
So you can't test.
you can't test stimulants for
Okay.
xylazine, no, because it will always be positive.
Good to
Just a
know.
couple of little things, if you are able to access it, we will send it out electronically, via email, just make sure that you have signed in. And if you weren't on the original registration list, just make sure we have your information to contact you. Thank you, Danae, for being here and presenting. If you have any other questions, you're on here for a couple more minutes, if you have any questions. But thank you, everybody, for your.
Thank you so much.
Oh, thank you. Yeah.
Yeah. You don't have to be the one. You know. Oh, thank you. Yeah, thank you so much. Yeah. The only thing.
Yeah, it was,
We'll be forever.
yeah.
Yeah, no, definitely not.
So, like, happy guards, yeah.